Hello, everyone, and welcome. I'm Alyssa Eppel. I'm a professor and vice chair in the Department of Psychiatry and Behavioral Sciences at UCSF. Thanks for joining us and being part of this virtual experience. Before we start our session, classes without quizzes, building stress resilience to withstand the next crisis, a few housekeeping details. To submit a question, please use the chat box. We want your questions. We have some time at the end. Please keep your questions brief. They are public. And given the size of the audience, we may not be able to answer every question. So many of you joined our UCSF alumni webinar pop-up series, which started a year ago, and it was on emotional well-being during COVID. This is the first webinar in our second new monthly series on continuing current and unfolding issues in coping with the pandemic and beyond. So I welcome you to join the full series. You'll hear about it from the UCSF alumni follow-up email. The COVID, you might recognize my office. I was here a year ago, and to be honest, it all feels very fuzzy. We didn't know what we were in, and we still don't know exactly what we're in for. So this is our new world as it unfolds. The COVID-19 pandemic has been devastating for our whole society, our whole globe. And before I move on, I do want to just have a moment of silence for all of us to just sit back, close our eyes, and really have a moment to memorialize all of those who have passed during this pandemic. So we're at a transition point. We're at a bridge of re-entry while we're still battling with COVID outbreaks here and in a terrible way in other countries. How are you feeling? I would like each of you to just check in. What is your level of fatigue, anxiety, hope? How much are you able to feel joy? Many of us feel pandemic fatigue at this point from a long period of coping, of staying well, of helping others, being isolated, many sources of grief from losses, unnamed losses. Many of us might have a feeling of burnout, numbness. And what we're going to focus on is the myriad of mental health issues that we have struggled with, our family members, our friends, our colleagues. There's also an anxiety that is lingering that we're calling re-entry anxiety, which is things are changing, we're in another transition point. And we want to acknowledge the grief, the losses, the hope as we go into this new stage. So we're going to deal with some of these issues in our new monthly webinar. It's the first Thursday of the month, 12 to 1, and we will discuss lifting this grief and pandemic fatigue so we can embrace this new world, so we can more fully feel joy again, even with the sorrow we feel. In the wake of another murder of a Black man, it's another hard day. We know we need to work on race equity and social equity. None of us can be well without that. So we will discuss in our seminar creating an anti-racist setting and culture in our own clinics, in our own communities, and in our healthcare settings. And we will touch on that today, but we will have a whole session of that in our webinar. During the fire season, we will talk about the power that we have as healthcare professionals to help mitigate the climate crisis and cope with it. In the fall, we'll talk about strategies to help our youth transition back to school, back to work. So today we're going to focus on the mental health impact of our healthcare system. When an event creates distress and disorders in the majority of our population, we can't take an individualistic approach. This is also a pandemic of stress and distress, of compromised well-being, and of disorders. And normal disorders, normal responses to what we're experiencing. So we need to think about how to help people at their different levels of needs, levels of risk, levels of disease. But it's also this period of hope, transition, and change. So that's what we're going to talk about: individual and systemic resilience, and in our healthcare workers, in ourselves. We need to prepare our minds for this new world going forward and support networks for the next disaster. We have experienced communal trauma, and it will take systems thinking to move us into communal healing and not going back to business as usual. We need to change our paradigm. We think of preventive care as, we pay for it, we accept it. You go to a doctor to prevent physical disease, you do daily behaviors for physical disease, but we don't think about that for mental health. We want to shift toward prevention. So today, I'm just so happy to bring you 3 national experts on the front line of these issues. UCSF faculty. We will hear from Christina Mangurian, professor in psychiatry, our vice chair of diversity and health equity for our department. She is during COVID has championed issues of parenting, particularly women parents who are clinicians or researchers. She'll talk about that report. She has awards for mentoring and the advancement of women in science, and she's helped lead the effort for coping and well-being at UCSF with Margot Kumar, with me, with many of our colleagues. We're also very honored to have Maja Jackson-Triche today, who has overseen this whole COPE mental health effort at our institution. Maja is a professor in the Department of Psychiatry. She is an assistant vice chancellor and UCSF Health Executive Advisor for Diversity, Equity, and Inclusion. She was a chief mental health officer for a VA network of over 1 million veterans in the US and abroad. She was responsible for their mental health. She also oversaw the VA's mental health response in New Orleans during Hurricane Katrina. And what she did there was phenomenal. She brought those principles and skills to UCSF, and we'll hear about those today. For her role there, she received the Veterans Integrated Service Network Award for Outstanding Leadership. I'm so glad you could join us, Maja. And our third guest today, I'm so happy to have Robert Rodriguez join us. Some of you might remember Robert joined us at the beginning of the pandemic because while being an emergency medicine physician working full-time in the front lines, he also mounted a large national study on the mental health of emergency care providers. He has published 8 papers during COVID. Don't ask me how that's possible. But he was also appointed during this time to the Biden Transition Committee on COVID. And so we will hear about his research on the mental health impact on frontline providers. So I'd like to, first, I'm going to hear from the panel one at a time, just briefly about what is resilience? What has the mental health impact been for you, for those around you, and what are your sources of resilience? And so I'm first going to turn to Robert because he can also tell us the profile of mental health from his national surveys. Welcome, Robert. Good to see you again.
Thanks a lot for having me here. As you mentioned, the pandemic has had profound impact on the mental health resilience of providers, healthcare providers across the board. And we noted early on, very early on, like in February and the beginning of March, a heaviness, an anxiety developing in our frontline providers. And so we undertook several national studies of that, of the effects of the pandemic on the mental health, on the anxiety levels and risk for post-traumatic stress disorder in frontline providers. And that includes nurses, doctors, other emergency department staff. And so we basically, in a number of studies, started a longitudinal program to look at these effects. And what we found were profound effects on the anxiety levels of providers, not only at work, but also at home. They were bringing a lot of the effects of the anxiety in the workplace home to their home life, and that really affected their interactions with family members and friends. They were afraid to have close contact with them. They found that the family members and friends were reluctant to have close contact with them as well. Conversely, people were doing things like showering outside before they came into the household, and oftentimes staying away in hotels during in between shifts instead of going home. So we found profound effects on the workplace anxiety and home life of the pandemic. We also measured over time burnout in another one of these studies, and we found that over half of providers had some level of emotional exhaustion and burnout, and over half of them also had at least one risk factor for post-traumatic stress disorder. And using a scale, and I want to thank you, Alyssa, and others for helping us with these projects, by the way. We found using one of a validated scale that approximately 20% of providers were at significant risk for post-traumatic stress disorder. So I think that the first step, from my standpoint, or at least from the first step toward resilience, is recognizing that the problem exists, and recognizing that it exists on a national scale, and recognizing that it exists personally. And I certainly have felt waves of emotional exhaustion throughout the pandemic. And I think that, as you mentioned, the issue of stigma, it really needs to be destigmatized. We need to recognize that we need to make it such that providers and everybody can feel honest about those feelings within themselves, and not afraid to get help. So that's a major point.
Such a major point. I think destigmatizing mental health has always been an issue, and it couldn't be more emphasized now. And I think people experience, everyone is vulnerable to mental distress, mental disorder, having interfere in our relationships, our life, our work, our sleep. And so that helps, but it's more of an opportunity. What are we going to do with that? Thank you so much, Robert. I just admire you taking on mental health on these frontline providers so much. Your research is really leading the way. I'd like to turn to Christina.
Great. Thanks so much. And yes, thank you, Robert, for sharing that experience with the frontline providers. You know, it really echoes a lot of what's known in a lot of these pandemics. Some meta-analyses have been done before. Nothing's quite like COVID, but in other kind of diseases that really, you know, frontline providers, especially nurses and docs and women and caregivers and people who have lower socioeconomic status, or are at high risk of whatever the disease are, or socially isolated, then can be very much at risk. And I've definitely found that some in my work too, looking at physician mothers, where, you know, 40% of physician moms across the country had evidence of moderate to severe anxiety during COVID, you know, and I think, Alyssa, you were kind of wanting us to talk about what was our own experience, right? And so I think I'm like many of the people that, oh, what were you going to say?
Well, before we move on, there was a striking gender difference in Robert's data. And I wonder, Robert, if you want to comment on that. Did it surprise you? What was the gender gap in PTSD symptoms?
Yes, that is an important point. Thank you for bringing that up, Christina and Alyssa. We did find that female gender was associated with higher risk, significantly higher risk for burnout and for risk for post-traumatic stress disorder, with odds ratios almost approaching 2. In other words, right. Twice as likely right. to be at risk. Yeah, that's a very, very important point.
Yeah, we had a report from our caregiver task force that Christina will talk about, and I just felt like crying hearing about it, because you hear a statistic, women are more at risk, and we knew that before the pandemic, and now it's, you know, magnified. And then you wonder why and what can we measure to explain that, you know, but there's no mystery here. I mean, when I heard the women testifying about what it was like to be at home and be expected to work and have kids there, and you know, all of the kind of double burden and these roles, I felt like we needed the narrative to understand it and have it fleshed out and talk about solutions. And I think that we need to validate what that extra burden is and try to ameliorate it. So Christina, let's go back to kind of what was the impact for you? What were your sources of resilience? And then also what are these, you know, sources of resilience system for women and caregivers and
Sure. Yeah. No, I mean, this is an area I'm pretty passionate about. And I think that, you know, we're not quite there yet with equity, both at work or at home, right? I think that COVID has revealed a lot of inequities, and definitely all over the news is about the real concern about losing our professional women in the workforce, you know, in the sciences and across multiple domains. So I'm like many of you, right, who might be watching this. I'm a physician. I had multiple roles at the university. I'm a physician scientist. So I have mentees, people working in my lab. I had my fellows. I had administrative role. I had my patients. And those were all different populations at work that I had to worry about, right, and make sure they were okay when the pandemic was first hitting, and that I could manage, and making sure I was communicating well. But then I was like many of you, I'm also a working mom. I had an 8-year-old, I had a 12-year-old at home, I had a husband. I'm normally the primary breadwinner at home, but he completely lost, you know, was not unable to work. I had 2 elderly parents and 2 elderly in-laws. So I had a lot of people who I was worried about and responsible for. And thankfully, you know, I've been through rough times in the past, like many of you too, you know, and I know that Maja is going to go into some of her experience at Katrina. I think having that experience helped me kind of know I need to build up everything I can so I can stay as strong as I can, because I actually knew that if I stayed strong, that actually would help my kids and help my staff. And so that was the right thing to do. So talking about stigma, right? I will self-disclose, which I haven't so much, you know, in my life before COVID, but, you know, I went to therapy. I took an SSRI. It's really helped, you know, like it's helped me to sleep and maintain my well-being as much as I can. I exercise. I spend quality time with the kids outside, even though my work has gone up dramatically. I make sure to carve out an hour every day that I spend just with them, and we're outdoors so that I get outdoor time, limit alcohol use, have a regular schedule, and then really prioritize my family, you know, I was really worried about my parents getting isolated, so called them a lot because I was worried about them. So we called them every day to make sure they were okay. And then I set up things, you know, so that the kids had grandparent time. And so there was time that the kids could be with the grandparents. But those were things that I did for myself. In no means did I do it perfectly. But I did it good enough so that the kids are still, you know, they report being happy, which has been very, very important to me throughout this, as it was so painful. I mean, I know all of us San Francisco has gone through its different waves, but I think I remember in the beginning, since I trained in New York, it was very painful to watch my brothers and sisters there and at home, knowing people like you, Robert, were on the front lines and so much in the midst of it, really drawn to, as all of us have, to use our skills to best help others during that time. That was helpful to me as far as my resilience.
Thank you so much, Christina. You've done so much for others while you've been coping so much at home. Maja, welcome. You're on mute.
Getting used to Zoom, sorry. I really appreciate everyone's comments and just want to say just a little bit about how I coped, to add to the discussion. I think that one of the hard things about being in a disaster, and a pandemic is a disaster, is a sense of powerlessness and uncertainty. And they're real. I mean, that's not imaginary. You don't know what's going to happen. You don't know what's going to happen from moment to moment, let alone day to day. And we still have a lot of uncertainty, especially with the news about the vaccines and some of the side effects. So now people are even becoming nervous about what appeared to be a solution. So it's really, really hard. I guess when I think about resilience, my definition is the capacity to recover from a trauma and heal, which is an ongoing process. So it's not an endpoint, it's an in-process kind of thing of keeping yourself as healthy as you can. And a couple of things that I did, in addition to the things that Christina mentioned, was having a very intentional online support group. For me, I reached out to friends and they reached out to me, and we decided that it was very important for us to get together every week. So as of today, every Thursday, there are two close friends who I've known since residency and hadn't actually talked a lot since residency, but we talk together. One lives in Germany, and the other person is back east. Every 7 o'clock, every Thursday, we talk. And we talk about all sorts of things. And I've noticed that we've gone from, being really upset to now actually having some laughs about what's happening, because we're feeling like there's a little bit of light at the end of the tunnel. And the other thing is that I have a spiritual practice and a meditation that I do that helps me. And Alyssa has asked me to share that. And so at the end of our conversation today, I'll share with you the practice that I use. And it's very, very brief. I modified it from a practice that I had learned about with someone else, but it's been modified. And so I'll share that with you towards the end. So I think I'll end with that, Alyssa.
Wonderful. Thank you so much. So I'd like to invite all of you back to the screen so we can have informal discussion. The word isn't formal and Zoom don't go well together, but we're going to be talking back and forth about model aspects of institutional resilience and models of that. And so, Robert, we'd love to hear about how to support clinicians. I think we know so well by now that we started with a context of high burden and burnout for our providers. So they entered COVID with a state of depletion in many cases. And we also know that we tend to treat mental health conditions, including burnout and that kind of continuum to depression, as a individual problem. In a way, we blame the victim, but it's a systemic problem. It's the problem of the workforce and the lack of resources. So I would love to hear your ideas, and I know you've published about this as well. And Christina and Maja, I think we can jump in from there to talk also about what we've done at UCSF.
Okay.
Thank you.
Well, thanks again. And I think from a frontline provider standpoint, it really has to be incorporate a holistic kind of view, a holistic approach. And some of the things that Christina and Maja mentioned are outstanding, like foundations for that whole holistic approach. We're talking about starting at the personal level with recognizing that it's indeed an issue. Number one. Number two, recognizing that that it should not be stigmatized, and that you should be, we're all sort of taught and ingrained in residency that you have to be like, quote, strong, and that and we have to kind of battle against that thought that recognition of this anxiety and exhaustion and burnout is a point of weakness. It's not. It's recognizing it is a point of strength. So we talk to our residents and our faculty and providers about expressing your susceptibility or vulnerability, and by doing that, you're being strong, not weak. Mm-hmm. And so so a lot of the things that you mentioned that others mentioned, including like spending time outdoors, maintaining some sense of community that you can on a personal basis, and then moving up to like departmental things. And so our department, and that being the Department of Emergency Medicine, we've had regular sessions to discuss the topic of COVID in our weekly sort of conferences. We've had a number of other departmental type programs to support our faculty and our residents and staff. And then moving up from the department, it goes to the medical school, and UCSF has been wonderful. And a lot of the programs that all of you, the co-speakers in this, have set up, those are great. Those have been fantastic. We send links of those programs to our residents and our faculty, and so it's really a pyramid of holistic approach, starting with the personal level again, moving to the departmental level, moving to the institutional level of the medical school, and then even further on up into the national, the state and national level. And certainly during my time with the advisory team, the Biden-Harris Advisory Board, this was and it remains a big issue. They are looking into national type programs of support. So again, I view it as a holistic kind of pyramid, from personal all the way up to a national level of support.
Yeah.
Beautiful. I have so many more questions. Have you seen signs of culture change? If you could change, one thing systemically for you and your colleagues, what would it be? It still sounds like so much individual work, and it is. It's, as we've talked about, daily management for maintaining emotional well-being. But in this strained medical system, there's so much strain at every level. Whether it's an administrator in a clinic or a frontline nurse or physician, how do we, besides the individual things, how do we change the culture to be more supportive? I love what you said about reaching out is a sign of strength. Expressing distress is the first step, but seeking resources, therapy, talking about it is, should be rewarded and applauded and congratulated, but we kind of whisper about it. We still whisper because there's still this kind of inherent shame on it. So I love that you're changing the culture there.
Yeah, well, if I can say a word, Alyssa, one of the things I found out from dealing with Katrina is that it's really important that we pay attention to setting up structures that allow people to find the help that they need and to then apply their own individual kind of resources to help themselves heal. Because as many of you know, in New Orleans, everything was just flattened. Everything fell apart. and so that it was a matter of trying to just get resources to people. In fact, we were setting up MASH units in parking lots to try to get care to people. And it brought home to me the essential and foundational need for mental health care, because people have physical problems, but equally, people are emotionally and mentally traumatized by disasters like that. And the same thing was happening with COVID. And so one of the things that I think it was really important to do at UCSF and why we developed this program was to set up using principles of equity and access as guiding principles. We thought and clearly we were starting to hear very early on about the significant stress with healthcare workers and essential workers all the way down. We thought it was important to set up a way for people to get mental health care, which on a good day prior to COVID was hard for many people to get. And we said, well, especially for the people that we know are very stressed, we need to set up a system and a structure so that they don't have to think a lot about where they have to go, that it can be pretty automatic. So that's what we did here by setting up, the web pages and, online access for people. The other thing that we did was divide people up into populations. We took a population health approach, saying we know just off the bat we're going to have some populations that are stressed, and that's the primary issue. We don't know about the level of stress at this point, but that's going to run a gamut. But then there's another population of people who are becoming stressed and maybe beginning to have symptoms that are significant enough that they need to be assessed. So that was an area. And then the third group were people who already had been, sort of diagnosed or knew they were suffering with a particular, emotional or mental health disorder, and were either having trouble getting care from their regular providers or felt that their symptoms were worsening. So we set up a system where someone would not have to sort of diagnose themselves, but they could go to a one-stop kind of shop where they could get an assessment through a chatbot and then be directed to materials that would help them. That's sort of a quick overview of that, but we thought that that was very, very important to do. And of course, we set up the web page with the support services that you and Christina were so fundamental and foundational in getting that together. And you can both talk about the kind of resources and materials, but it's been highly successful. And to date, we've had tens of thousands of people who've used it.
Yeah. And has it been mostly used? Has it been also used by our service workers and
it's been used by everyone. In fact, a couple of people have given little testimonials that they've sent my way, and people. One of the receptionists told me that she's been the COPE program champion. She tells all her friends about it, and and some of our hospitality staff have used it very well. And one of the people who's worked closely with me, one of my assistants, finally disclosed to me later that she was one of the first people to use it. So it's been broadly used. And outside of UCSF, it's been used as well.
Yes. And what I love about the program, and Maja, and your vision for this in the beginning, is that exactly that, the broad equity lens. And so there's some providers who are clearly on the front lines, like you, Robert, you're in the ED, or a nurse in the ED. But do we think about the custodial staff? Do we think about the different players that are really on the front line? Like, I wouldn't have even thought of radiology as being on the front line, but chest radiology had to be in there. And so just it's the fact that the program, the UCSF COPE program, was set up to think about the whole population, and all employees counted, and anybody could enter in and receive basically the services that you, Alyssa, were able to build through the website, where you have videos that people could watch to get, tools that they could use themselves as they'd like, or deal with our kind of, as different traumatic events happened, deal with those things. So, whether it was the wildfires that you mentioned, or political stress, or really massive racism, racism events, that happened with the death of George Floyd, all of that contributed to the stress that our community was experiencing. I think that, like you were kind of mentioning about culture shift. I mean, I think that if I was to rule everything and be able to change how organizations function, organizations would have something like this in each of them. And we have a massive destigmatization campaign, would make sure that there was easy access to mental health care should they need it, would be promoting self-care, and not just among the frontline staff and everybody, but also for leaders to show that they too, care and support themselves and get the support they need, and just have it be much more of a focus on our general health and well-being in a real sense that includes mental health that's so stigmatized. Oftentimes we create this dichotomy between wellness and mental health, which is a false dichotomy, right? But you need to have the ability to move up to the level of care that you need. And that's, again, what I really liked about COPE, is that you could come in and get things, not everybody needed to go see a psychiatrist, right? For some of them, they could receive things like we did, I think, Robert, I'm sure, in the emergency department, using different town halls where we might meet up with employees and go through, what was hard for you, sharing the stories among each other, sharing what you did to take care of yourselves. Often people can just communicating with one another, like Maja, you were talking about with your friends, just talking to each other, you get little hints, little pearls that might help you. And those things are so valuable. So I think what's exciting is that I think that people recognize, because we've been so isolated, that it's clear this has had a mental health impact on everyone. There's an opportunity now for us to make, as a society, to really take this, go forward and really make some change.
To look at the model. Yeah, and the other interesting thing is that we're really piloting a brand new modality. Telehealth has been around a while, but we've really started to scale it and finding out that it's really very helpful and a successful strategy.
Right.
I want to thank all of you personally and on behalf of our department for your development of those programs, and you really hit the nail on the head. And in one of our last studies of the effects of the pandemic, we looked at not only the doctors and nurses, but we included custodians, we included clerks, people that were not directly involved with patient contact and did not have direct patient contact, and we found that it's pervasive, that
yep.
It's really across the board. It also a little bit surprisingly, the effects were consistent between, this was a national study, but between sites that had tremendous surges of patients and sites that did not have like these great surges of patients. It was really a consistent effect across the board. So I'm glad that you are opening up these programs to everybody, and regardless of whether they're deep in patient care contact or not.
Yeah, and I think that it really is, I will say, Maja, that had been your vision, because that's very different from what they've done in other places. So other places in the country have been trying to deal with this, obviously, as well, but did deal much more with creating programs for faculty or for the physicians. And I think that makes sense, but I understand why those decisions were made, but I think it makes much more sense, I guess, to me, to approach it from a population health level. And also it's an equitable thing to do, right? Like,
yes.
You're treating those with the most privilege, right? The physicians who can go get care that anywhere else, and you're prioritizing those. I think the only other thing that I would add to this too is the importance of these supervisors You talked in the beginning, Alyssa, about like how how so much of it has to do with the institution and what the institution does. And I think there was something that we worked on a lot is realizing, look, we can't help everybody, right? We can't touch every single human being here. I mean, we can through this, but we could have a big impact if we support the leaders. Because just like how, you may know mom's okay, baby's okay, right? The same thing goes if your boss is okay or your leader's doing okay and is healthy, and then employees are well. So if the employees feel like their boss is actually somebody who cares about their well-being and does things like, check-ins during meetings, normalizes seeking care, recognizing stress, giving people breaks, making sure people don't have Zoom fatigue. These are all things that I'm sure people watching this are thinking about for their employees. That has a huge benefit for your employee bodies, especially those who are the least privileged in your groups.
So I'd like to think about, in 5 years from now, what would you guys like to see maintained and more of? And what would you like to see less of? So I think preparing for our future, looking ahead, we know that this was quite a big earthquake for all of us, but it is going to become more common, that because of climate change and other natural disasters will happen, including zoonotic diseases. So this was, we've learned a lot and we're worn and torn and seasoned, but we forget easily. And there's pressure to go back to business as usual. And most of us don't want business as usual. We want a better world and a better system. And now is the time to really be thinking about how to be vocal about the changes we want to keep. For those of you listening in your own institutions, it would be great to hear from you what questions you have about how to implement a COPE system. Robert mentioned the triangle, and it was specifically is a triangle of a public health model of resources for the community, for everyone, and trying to really push that out. Town halls and talks for groups who are particularly high risk, like our essential workers and frontline providers, and the individual treatment for those at most at risk or prone to already have mental health issues and they were at high risk of getting worse. So it's a multi-layered system, and there are principles of building a system like that Maja can talk more about. But I would love to think about how we are prepared emotionally, resource-wise, and in our, how are we prepared for the next disaster, and how are we not prepared? What is your vision? What are your worries?
Well, one of the things, I think it's not an if, but a when in terms of the next pandemic. And we hope that, we're not really out of this one yet. But I think that we clearly, if you're talking about a disaster preparedness model and a broader definition of disaster, clearly we have to have the backup plans in place. So I would hope that if something in 5 years we had another pandemic, the COPE model could be stood up very quickly. In the same way that we have earthquake preparedness and now hurricane preparedness better. I think also I would hope that we would take some elements of COPE and make that part of just the regular daily practice in terms of access and equity for people for emotional, behavioral, mental health issues that are coming up. Because as we know, that's a huge problem everywhere in the world in terms of getting appropriate and adequate mental health access. And so I think had we had that in place, we might not have needed a COPE. So I think that hopefully, we'll start looking at these structures, how you structure care, how you look at communities at risk and address that from a global or more national perspective.
I completely agree. I think that we need to have a playbook ready for the next natural disaster or the next pandemic or whatever it may come. I think it's also very important to recognize that over the past year, coming up on, more than a year, maybe coming up on a year and a half. It's the concerns and the drivers of stress have evolved, have changed. In our work, which was it's longitudinal. We found that the initial drivers of stress, anxiety were almost exclusively around PPE. It was around the issue of PPE and exposure, whereas later on, other concerns came into play as PPE was built up. Concerns about schooling for kids, financial hardships, and continued concerns about exposure to their families. So I think it's important that we have a playbook that is going to be nimble, such that we can kind of adjust for differences in whatever disaster it may come, but also differences along the course of the pandemic or disaster.
Mm-hmm. Yeah, and I'll just add to this. I mean, you mentioned about schools. I think so it's not within our locus of control as healthcare providers, to control the schools, obviously. But I think I would want, if I, again, what I might wish for in 5 years would be that we would have a really robust partnership between both the healthcare providers and mental health providers in the education system to basically be prepared for this and prepared for the backup for childcare for this, because this is how we all got hit so hard. I think as I mentioned and disclosed before, my husband had a hit to his work. So he became the de facto person that dealt with a lot of the remote schooling. I had to every so often, but not as much as I would have. And it would have been, it still was difficult for me. It would have been even more difficult had that not been true. And so I think that needs to be part of the, part of it, as far as, we've talked before about the women in the workforce, and this is part of it, as well as elder care. I think those are, that's who women, and the data shows this, are more likely to be the caregivers of the elderly as well as of children, and do more of the domestic work.
Mm-hmm. One thing that I think about a lot is, well, first of all, that the hard solutions and the systemic changes are absolutely critical. We got to keep our eye on the ball. But how we interact with each other is a really big determinant of both stress and support. And the race equity movement opened many people's eyes like they've never been opened before. And you can't go back. Once something is seen, it will always be there. And that has happened. It's an opportunity for us to change how we treat each other and to understand we're not just individuals, but we're the result of both historical forces and group dynamics that bias our thinking. So what's happened in our, small group, some of our small groups here, is being aware of both race, and if it's not about making sure there's equity for our Black members, for example, noticing we don't have the Black members here at all in the first place, and so there's this, oh my God, that systemic racism thing has such a long, funnel that it's gone through, that we need to really start back with our youth and our pipeline for real equity. And what I've really appreciated systemically is the messages from the top, Michael Drake's memo saying, we respect peaceful protest. People have the right for peaceful protest. Now, we know that legally, but to have your institutional leaders state these things, state the grief, the support, the mourning. So at every level, I think the trainings that you've done for leaders, Christina, have been a way for all of the different levels of groups, all the way down to someone who's supervising one person or 3 people, to have create these conversations, building on the structures that are already there, of support, of opening up dialogues, of checking in with people. I loved that Talmadge King, our dean, just sent a memo saying Zoom meetings should be 50 minutes. Well, we COPE people have been saying that for a year now, but to hear it from him, it was actually implemented in a more systemic way. So that was powerful. So it's those small changes. Community rules for how we interact with each other during meetings are something that happens in very conscious communities and communities focused on equity. So, but we should all have those rules at our fingertips, and versions of them that work for clinical groups and academic groups. Things like listening to how to listen to people, how to approach conversations with humility, and not make it a right versus wrong, but to have real listening and dialogue and sharing. Those are not easy skills. Most of us aren't trained in those, and we could all be. I think I'll post a link to that on our resource lists. So we're going to move on to the role of the media, but before we do that, any more comments on kind of keeping up the momentum of the race equity movement? How do we make the changes that we see what's needed, but making them is so hard and slow? And we all know it's a slow process, but how do we hold on to that momentum?
I'll go first. This is a hard, I mean, I think, look, in our, I don't think in my lifetime will racism, sexism, homophobia, xenophobia be extinguished, right? This is not, this is just not reality. However, maybe the other speakers feel differently, but I just, I don't think that's possible. That said, what I do think is possible is I think there's a lot of people who, as you said, Alyssa, whose eyes kind of opened up and are more aware. And there's a lot of allies. There's a lot of people who are starting to really think about these things. And I believe in policies and procedures. And so I'm a big proponent for putting in policies and procedures and monitoring data and using those kinds of things. I mean, I definitely think education is important, but we have to know that the education can't get rid of our implicit biases. That it's not possible. So all of us have these implicit biases, and they don't go away. And so how they rear their ugly heads is when we're unaware of them at final calls for decisions to select leaders or choose who you're going to employ, whatever. And that's what we have to work against, and or treating our patients, right? Okay. And so I think what we can take from this is that leaders and frontline staff and everybody, I think any energy that they're putting in to counter, to be more anti-racist and to do good things in our world, I'm going to encourage that. Yeah. Like, I think it's important, but I'm a big policy person. So for those in leadership positions, policies. Mm-hmm.
Mm-hmm. Well, I think the comment that I'd like to make is to say, I think the opportunity and challenge of the moment is to really deal with structural racism. Yeah. And the structures and institutional practices, the systemic things that support racism and racist behavior. And I think that's the piece we've always sort of, so far in this stage, dealt with it as an individual kind of preference and behavior, but we've learned that there are larger things. So I think moving forward, we're going to have discussions about that. I know that UCSF, we're having discussions about that, which is how my role came to be, actually. Mm-hmm. So I think that we have a lot of opportunities to at least plant the seeds of the mitigation and finally elimination of racism and discrimination and bias. Mm-hmm.
I'll just offer an example of a search committee I was on where we didn't get any underrepresented minority candidates. And so I went back and looked so carefully at all the advertising and networking, and they had done best practices. They had done everything on the book and checked off everything, and it wasn't enough. So our systems have to change, and then there are time pressures. And so, and then a position is filled because of need. And so so I think the old ways of looking at resumes and recruiting is not going to work for us.
Yeah, this all has to change. We have to take a different look. Yeah.
Well, I'm going to give a quick answer to the media question, and then we're going to get to sit with ourselves together in a final moment of kind of
meditation,
spirituality together.
Yeah. Okay.
A word we often don't use in our medical system. So someone asked about the role of media, and I'm going to refer you to our beautiful website. We really do want all of you to utilize our website. We spent months and months, and we still update it to talk about the role of vulnerability and resilience factors. And the media is a big theme on our website. And the short story being that it is one way that disaster leads to PTSD. Is overdosing on the images and the media and many sources of media. So, and it's just so important to protect ourselves and our children. Okay. And so let's see, Robert, did you have any last comment before we move to sitting?
Well, I think that my last comment is that it's important to chronicle our feelings over time. I know that from both personal experience and other reading about other people's experience is that you will, 2 or 3 years from now, you may not, things kind of blur into each other. And so I think it's important to chronicle not only our personal feelings, but about how we were feeling at one particular time during the pandemic, but also for there should be institutional chronicles of what happened and going over what went right and what went wrong. So I'm a huge proponent of that, and in fact, in getting involved in a commission to do exactly that. So I think that things get blurred over time, and so keeping a chronicle of what happened and what felt.
It's an incredible suggestion. You've brought it from the individual level also to an institutional level to do this chronicling. We'll talk more next time about using creative expression and writing for coping with grief and trauma. Maja.
Okay, so what I'm going to have to do is shorten this a little bit because I think we only have 2 minutes, right?
Why don't we make it, do you need 4 minutes?
I need a little bit more. I'll shorten it a little bit so that
it's fine. I think we can cut off on the tape. We can cut off the beginning. So it's fine to take what you need. Thank you.
All right. Okay, so what we'll do is have everyone sit and close their eyes, and I'll begin. So I relax my mind and my body. I surrender to my own inherent gentleness, and I bow to the natural world. I feel calm. I feel connected. I surrender to the mystery. I know that I am a part of the circle of life and that I am of this natural world. May the calm and peace I feel serve as added vibrational calm to our precious world. And now to breathe. I breathe the breath of life. Inhale, belly rises, ribs expand. Exhale, belly softens, ribs and chest soften. Soft heart. Inhale, belly rises, chest expands. Exhale, shoulders soften, body softens. Inhale, belly rises, chest rises, give thanks. Exhale, soft belly, soft heart, shoulders are water, give thanks. Soles of feet, soft and safe. Crown of head, luminous and bright. One shimmering body under the moon and sun. Breath of life, one body made of earth, made of stars, made of water. Give thanks, give thanks. So that's the end. And this is adapted from a longer meditation that Morley does. She's a singer, and it's morleymusic.org if you want to look that up.
That's beautiful. We can post that. It's a beautiful way to end. My body really did change states just now. It was so nice. Thank you so much. Thank you, everyone. I hope to see you all in a month at our next event. And if you're part of the alumni weekend at 5:30, you can hear Chancellor Sam Hoggood in conversation with UC President Michael Drake. Have a good day. Thank you.